today's episode of Marvelous Medicine. We have put together a panel from across the world and we are going to be discussing about acute pain services. Let me take a few minutes to introduce your panelists in alphabetical order. We have Dr. Angela Deely. She's a consultant anesthetist and lead for acute pain services at Mid Cheshire Hospitals at the NHS Foundation Trust in England. She graduated from the University of Newcastle upon Tyne, after which she completed her FRCA. Her ophthalmic colleague, Dr. Venkataraman Rao, is my batchmate and friend, and I'm thankful to him for having introduced me to Angela. Angela, welcome, and we hope to hear from you. Dr. J.Balavenkatasubramanian needs no introduction. He's a world authority in anesthesia, pain, and regional anesthesia. Despite his extremely busy schedule with meetings all the time, he readily accepted to join our less known Marvelous Medicine, and for that, I'm very grateful to you, sir. Dr. Balavenkat is the Senior Consultant Anesthesiologist and Academic Director, Department of Anesthesia and Perioperative Care at Ganga Hospital, Coimbatore. He did his MBBS from Coimbatore Medical College, DA from BJ Medical College, and MD Anesthesia from PGI Chandigarh. He is the President of the Asian Oceanic Society of Regional Anesthesia and Pain. He is the National Chairman of the Academy of Regional Anesthesia of India. He is a member of the Educational Committee of the World Federation of Society of Anesthesiologists, and he is also the current Governing Council member of the Indian Society of Anesthesiologists. Welcome, sir. From across the globe, we have Dr. Keyuri Popat. She is the Professor of Anesthesiology and a Medical Director of Acute Pain Medicine at MD Anderson Cancer Center, Houston, Texas. I'm extremely thankful to my friend, Dr. Radha. We did her MD anesthesia around the same time in JIPMA for introducing me to Dr. Keyuri. Dr. Keyuri did her MBBS from Lokmanya Tilak Hospital, Mumbai, after which she did her MRCP in internal medicine in UK. Something made her turn to anesthesia, and she did her anesthesia residency in UTMB Galveston, Texas. Welcome, Keyuri, though it's an odd time for you. From the Middle East, we have Dr. Sendil Kumar Muthu. He's a consultant anesthetist and associate section head of anesthesia at Bakra Hospital, and also the corporate lead for acute pain services, Hamad Medical Corporation at Doha, Qatar. He did his undergraduation from Annamalai University, MD anesthesia from Bangalore University, after which he did his fellowship both in UK and Ireland, and he's also done his European Diploma of Anesthesia and Intensive Care. Dr. Achyuta Ramaraju introduced me to Dr. Sendil, though I realized later that he's part of the anesthetist group and actually didn't need introduction. Thank you, Sendil, for readily accepting to join. Last but not the least is Ms. Sherin Chandy. No pain service can run without a lead pain nurse, and most of the pain services across the globe are nurse-led. Sherin is the pain management nurse at Fortis Hospital, Mulund. And I thank Shashank, a colleague in Fortis Mulund, for introducing me to Sherin. She did her BSc Nursing from Jaslok Hospital and her MSc Nursing from Bombay Hospital. She has received certification in Six Sigma and Quality Control Management. She has presented papers and won prizes in many conferences and has publications in national and international journals. Thank you so much, Sherin, for joining us. Now I'd request Dr. Bala to just say a few words as to what we intend to do today.
At the outset, I would like to extend my very sincere thanks for the enormous efforts that are taken by Dr. Patta Radhakrishnan and Madam Vidya Mohanram for making this forum very vibrant, taking up topics of great relevance, which would make a difference in the life of every patient. And I think Marvelous Medicine, as the name stands, I think truly what is discussed would marvel and enriching people around to make patient care better would be the ultimate motto. Thank you so much, Madam, for doing this. Today's session is probably one of the most important one and possibly the most neglected one, in spite of the phenomenal progress that we have made in technology, in pharmacology, in the human resources management. One thing still stands very difficult to accomplish, and that is making every surgical patient pain-free. Even the latest studies indicate that in majority of the center, close to 50% of patients still have significant post-operative pain, which clearly indicates there seems to be some gap that needs to be filled in by each one of us. And during the course of this session, I think we will learn from each other, evolve strategies, try to implement things which we learn, and make sure that every surgical patient who passes through us has got a VAS score of less than 3, at least during the first 48 hours, when the intensity of the pain is extreme. And if we accomplish this goal, I think this session would mean a lot to every patient who comes to us. I'm looking forward for a great interaction, and I'm very, very happy that we have representations from across the globe treating different kinds of pain. And I'm sure cumulative wisdom that would develop today will help us evolve better. Looking forward for the session.
Thank you, Dr. Bala. We were unable to get convince somebody to lose their sleep from Australia. Otherwise, we would have been really across the globe. So getting down to the brass tacks, Kayuri, can you please tell us the necessity for pain assessment and what are the types of pain does the acute pain service handle?
Sure. Thank you so much for this opportunity. And like Dr. Bala alluded to, acute pain is really an issue that has been neglected. And in spite of all the efforts from and a lot of research that has been done, we still see that almost 50 to 60% of our post-operative patients have moderate to severe pain. So pain, by definition, is a somatosensory response to a nociceptive stimulus. But as empathetic care providers, we really need to treat pain when patients say that they have pain. We have to believe the patient and go with that open mind and open heart to be able to take care of these patients. So pain has various components, of course. You have the intensity of pain, and how to assess that is something Sharon is going to allude to in a little bit. But pain has different characteristics too, and the types of pain that we all deal with is falls into like 3 main categories, which is somatic, visceral, and neuropathic. And depending on the type of injury, whether it's a crush injury or an actual surgical trauma, there will be different types of pain. And I'll talk a little bit more about it a little later. So we talk about the intensity, we talk about the location. We also know that it all depends on the type of patient that we have. Pain is a perception. It is not something, it's not like blood glucose, which is a physiologic reflection of what's going on in your body. The importance of pain management in at least the post-operative period is really important, because if the patient has a lot of pain in the post-operative period, that increases the chances of patients having pain as a chronic pain syndrome or even their physiologic recovery. So managing the pain in the first 2 to 3 days after surgery is extremely important. Most patients will get better and will learn to live with whatever discomfort they have within 3 to 4 days. So our role as providers is in that crucial post-operative period where we can influence change. With that, I'm going to pass this on to Sharon to tell us a little bit more about how to assess pain.
Sharon, you're muted. Sharon, you're muted.
Yeah, now am I audible?
Yes.
Yes. I thank Vidya Madam and the Marvelous Medicine team to give me this opportunity to speak on such a big platform. Now, coming to pain assessment. Now, pain is, as per the definition given by the International Association of Study of Pain, pain is it's an unpleasant, sensitive, and emotional experience with an actual and potential tissue damage. Now, like other vital signs, PPR, BP, pain is now the 5th vital sign. So we all might be thinking, what is the actual purpose of doing pain assessment? Now, this pain assessment would give us an information where we can understand what is the cause and type of pain. Pain assessment also helps us to know the impact of pain on the quality of patient's life and his ability to function. It also helps the patient, it gives a chance actually to the patient to express his painful experience. Now, this pain assessment, we can also have a standardized pain assessment documentation. Now the next question comes, how actually we should be doing pain assessment. Now there's a simple mnemonic which is there, easy to remember. In fact, it's OPQRSTU. So O stands for the onset part. So there we question the patient, when does actually the pain started? Is the pain an old pain? Is it a new pain? Or is the pain has become worse? And how long the pain remains? Now, after the onset, we question the patient on the P. The P stands for the palliating and provoking factors. Now, these factors, what cause the pain to start? What makes a pain best, worst? What makes a pain better? Now, once we question about the provoking and the palliating factors, then we have the quality of the pain. So there are different kinds of, so what exactly the patient feel like? Is it a burning pain, radiating pain, stabbing pain? So if it says, for example, it's a burning, pin-pricking pain, probably it's a neuropathic pain. And then we have after the quality, we have the severity of the pain. Now coming to the severity, how severe, how intense the pain is. For that, we have different kinds of standardized tools which are available. So the self-reporting tools which are available are the visual analog scale, then we have the numeric pain rating scale. Then we have the Wong-Baker scale, the smiley scales, which can be used for the children's. It can be used even for older patients. Now, the patients who are unable to communicate, who are like for the patients who are on ventilators, we have scales like the behavioral pain scale, then the critical care pain observation tool. Also, there are infants and neonates who can't verbalize how much pain they have. For such patients, we have the neonatal infant pain scale. Then for the older children, we have scales like the FLAG scale. Now, with understanding how severe the pain is, then is the treatment part. The next part is where we question the patient. Was the patient on any earlier treatment? If he was taking any kind of analgesic, did he have any side effects or any allergic reaction to those medicines? And finally, it comes to the U, that is understanding part, where how did the pain actually impact the patient's life and his family members too. Now, once we did our assessment, now how frequent it should be done. So first, it should be on admission. Then I recommend my nurses that every shift they come, so even for the doctors, when they come, every time they meet the patient, they're supposed to do the assessment of pain. Then is while they're on the shift, and there can be time when the patient can have something called as breakthrough pain. So in that case, they need to again assess. And if the numeric NRS score is more than 3, definitely they have to call the doctor and do some pharmacological intervention. And then once the intervention is done, the very most important thing that they have to do is a reassessment, which many of our people just avoid. They just do the intervention and just leave there itself. So in reassessment is very important. So for oral analgesics, at least after an hour, the reassessment has to be done. And for IV purpose, at least after 30 minutes, the reassessment needs to be done. We can also do the reassessment after you receive the patient after surgery or some invasive procedure what the patient has undergone. Now, lack of pain assessment is actually a major barrier for pain management. So coming to the last part, pain assessment is not where we just rely on vital signs. So if a patient has vital signs normal, we just say, okay, this patient will not have pain. That is not the case. Pain assessment is not where we decide knowing the procedures. So if a patient has undergone, for example, degescenting, the other patient has undergone a total knee replacement, we can't judge saying that a patient with degescenting will have no pain. Pain assessment is not where we just assess the pain looking at the face of the patient. So for example, today itself, I had a patient who had underwent exploratory laparotomy yesterday. Now she's a 26-year-old female. She was just lying down calmly. But when I asked her what was the pain score, she did tell me 5 of 10. When you see to that patient, it's really hard to believe really it would be 5 of 10. But I had to call my anesthetist, and then we had to give some top-up bolus. With the bolus, believe me or not, after 10 minutes, the beautiful smile what she had, it was remarkable. So we don't judge pain assessment based on the looks of the patient. Effective pain assessment with the appropriate response to the pain assessment would help us to achieve a good pain relief for the patient.
Thank you, Sharon, for that excellent briefing about pain assessment. You covered so many things in such a short time. So the current mantra for both acute and chronic pain is multimodal analgesia. And the things that are debated upon are the role of preventive and preemptive. There are people who believe in it, those who countermand it. So we cannot have anyone better than Dr. Balavenkat to give us a brief outline about role of multimodal analgesia and how effective is preventive and preemptive analgesia.
Thank you, Dr. Vidya. I think one of the most important things that all of us need to do in our hospital is to go for procedure-specific analgesia. I think each one has to evolve a strategy on procedure-specific analgesia. And I would like to quote the prospect, the website postoppain.org, which is promoted by the European Society of Regional Anesthesia. I think we are moving towards something called procedure-specific analgesia. And one of the important component of a procedure-specific analgesia is to work on the possible components of somatic pain, visceral pain, and pain arising because of an injury to the neural tissues. Hence, we know that we need to use more than one group of drugs to take care of the somatic pain, the visceral pain, and the neural pain. So it becomes like mathematics. We cannot treat total knee replacement similar to a laparotomy, which Sharon said, because in a laparotomy, the component of visceral pain is as important as the somatic pain, like incising the anterior abdominal wall. But in a total knee replacement is essentially completely musculoskeletal, more of somatic, and some of the neural components. So now that leaves us with the question of how to design your multimodal analgesia and what is the need for multimodal analgesia. The whole concept of multimodal analgesia came in because there was post-operative pain was essentially addressed with opioids. And the opioid use was with very, very high doses of opioids were given in the post-op. There were problems with this. Number one, opioid addiction to opioid. Number two, the consequences of using very high dose of opioids like nausea, constipation, respiratory depression. So it became very important to devise strategies to use other medications. So now, if we do any surgical procedure, some of the basic components of the multiple modes. Number one, drug is paracetamol. If the liver function is normal, I think paracetamol is the first drug of choice in the multimodal. And in an adult male, it needs 1 gram 6th hourly up to 4 grams to give good analgesia. Second, if there is no contraindication to use a non-steroidal anti-inflammatory drug, especially if the renal functions are normal, then we need to incorporate a non-steroidal anti-inflammatory. On day 0, when on the surgery day, if the patient cannot take orally, we need to go for intravenous non-steroidal anti-inflammatory. And one of the drugs which we use very commonly is injection ketorolac, 30 milligram given intravenously 8th hourly. That's a dose of 90 milligram. So 4 grams of paracetamol, 90 milligrams of ketorolac. To this, you add, now for the last 2 decades, has been regional analgesia, which has become an inherent component of several centers across the world. Thanks to the equipment ultrasound, you go for site-specific nerve block. For example, when we do a total knee replacement, we go and give a dual subsartorial plexus block, essentially a sensory block without affecting the motor and very site-specific. So when you do a spine surgery, you can go with a paravertebral block or a bilateral erector spinae block. So every part of the body, if we identify the nerve which takes the pain from that particular surgical area, need to be blocked. So paracetamol, ketorolac, regional analgesia, and the fourth one will be the use of, when the neural component is there, pregabalin and gabapentin. So this makes 4 different ways of decreasing or alleviating the pain. And to this, the multimodal, this 4 components, the 5th one comes opioid. When the other 4 are used quite appropriately, the requirement to use opioid as a rescue will become much less. And we are moving towards an opioid-free analgesia, thanks to some more drugs like dexmedetomidine, ketamine, and lignocaine intravenous. These are the other 3 drugs which have stepped in to aid us to do an opioid-free analgesia. So the advantage of multimodal analgesia is to decrease the opioid use, enhance the pain relief, and make sure that the complications because of the analgesic drugs is minimized on the patient. So now we come to preemptive and preventive analgesia. There is a lot of debate whether it exists or doesn't exist. But all the studies which have indicated that it works well, works on strong belief that once you administer a drug prior to a tissue injury, it decreases the central sensitization, and hence the requirement of the analgesics in the post-operative period is less. In our institution, we believe in preemptive analgesia. So on the day prior to the surgery, we put them on the paracetamol, one non-steroidal, and pregabalin for the patient. And so I feel since if there is no contraindication, it's a good idea to embark on the journey of doing preventive analgesia. And one more drug which seems to be of great help is dexamethasone, the steroid. Dexamethasone given 8 milligram prior to the surgery has been found to be a very good component of multimodal analgesia because of its anti-inflammatory properties. It decreases the inflammatory substances, the pro-inflammatory substances that are released during a surgical incision, and its effect on the nociceptor is minimized. So I think we need to move towards a mathematical procedure-specific analgesia, multimodal analgesia, preventive analgesia, to make sure that our patients' post-surgical pain is less than 3 in the first 48 hours.
Thank you, Dr. Bala. You have led us up to Kayuri, who's going to take us through the details of a procedure-specific analgesia. Over to you, Kayuri.
Thank you. So I think this is beautiful because I'm going to build on what Sharon said and what Dr. Bala said. So when we're trying to do a pre-op assessment of pain, we do everything that we've talked of so far. At least in the United States, a lot of our patients are on pre-op opioids. And so we do want to have MEDD calculation, the morphine equivalent dosing calculation of the amount of opioids the patients are on, because as much as we would like to go through an opioid-free post-perioperative course, if the patients are on a high dose of opioids, we don't want to have them go into a withdrawal during this process also. Also, the assessment would include all the details like Sharon said, but one of the big features that we concentrate on now is functionality. And actually, how much is the patient able to do pre-op? And most of the patients, their goal is to get back to what they were doing pre-op after their surgical experience. And so we spend a lot of time talking to the patients, understanding the functionality, and then setting expectations. And that's where our champions are our surgeons, because the surgeons spend a very big chunk of their time on setting expectations for recovery as well as pain management. Also, understanding the patient's family situation is also extremely important. And I'm going to highlight that I'm going to give you one big case that, that might highlight some of the points. So if you were to consider, I work at an oncologic institute, so I'm going to give you a cancer scenario. So if there's a 45-year-old male who has renal cell carcinoma, has metastasis in his humerus, and now has an impending fracture, and is coming in for a repair of that fracture. This patient is on pre-op on narcotics. So my pre-op assessment will not only include the amount of opioids that he was on before surgery, I will definitely be discussing, and my surgeon will be discussing, the different multimodal opportunities, including regional anesthesia with this patient. But we have to understand that even though it may be fracture neck of the humerus, it is not the same injury like a sports person has when they have a fracture neck humerus. This patient has a lot of implication to this injury, where it implies that this young man has got metastatic disease that might imply how his the rest of his oncologic journey may be, and thus his response to pain may be very different from athlete who has a similar injury. So even though you have the same nociceptive stimulus, it may not necessarily translate into a similar pain experience for that patient. So having said that, our surgeons would then make that invest that time in setting expectations. And the beauty of the enhanced recovery programs across the countries have been that we are all speaking the same language. We are talking about functionality, importance of movement, not necessarily concentrating and fixating on the pain score itself, but fixating on what the patient is able to do. At least in America, what happened was we were fixated on the pain score and created algorithms almost like a blood sugar sliding scale. Like if you have a pain score of 3 to 5, give this, 5 to 7, give this, 7 to 10, give this. And we got into a scenario where we were giving way too much opioids. And thus came the onset of the opioid crisis. So then the pendulum, like everything in America, we go from one end to the other end. So we swung the other end and went on to give no opioids to the patients. And we're finding that that may not have been the best thing for the patient. So because increasing pain, not having an adequate recovery will affect the way the wounds heal, etc. So now we're trying to find that nice happy medium with the multimodal analgesia, including regional anesthesia, to try and find good functional patients with adequate amount of pain control. So coming back to our patient, he went on to have his general anesthetic for his surgery and had a block, a brachial plexus block. Post-operatively, what are the things that we could offer to these patients? We offered not only the multimodal analgesia and the indwelling interscalene block, but we also had non-pharmacological treatments that we have to offer. And by that, we do use distraction techniques, like coloring books is what is kind of the in thing here. We have our chaplain who comes in to help with meditation that allows them to kind of concentrate their efforts in a different way. Physical therapists, we have a massage therapist, and we use music therapy to kind of help with utilizing all non-pharmacologic methodologies if we can to kind of make this pain experience more tolerable for our patients. We then try to use objective measures to measure functionality. Like, how do you measure it? It's very nice to say that we want a functional patient, but what does that mean? And we have gone down to utilizing all these fancy apps that we have on our phones nowadays, where we can talk about steps taken before and steps taken afterwards. And so we see a delta, a difference between how mobile the patient was before compared to what they were afterwards. We also utilize objective things, not necessarily in this patient's case, but if you had thoracic or abdominal surgery, incentive spirometry, and we see the amount that they should measure, they should be able to achieve, and what they are able to achieve. How much are they able to walk? Are they, because of enhanced recovery, as I said, the messaging was the same. Our floor nurses, which is our ward nurses, our surgeons, the surgeon's assistants, everybody has the same language and the same expectations. And that makes the messaging to our patients so important and uniform that the patients are almost tuned into. They'll come and tell us, next morning when I'm rounding on them on the acute pain service, they're like, I know I should have walked 3 laps yesterday and I did not do it. And they are the ones who are understanding what the expectation is and are wanting to meet that expectation. We do use, in terms of breakthrough analgesia, we do use bolusing of our catheters. Of course, we use our multimodals. We also add something more to what Dr. Bala was saying, and I don't know if it's available as much in India, is using muscle relaxants like baclofen and flexeril is what we have over here to help with some of the, some of the muscle spasms that the patients are having too. That kind of drives me into kind of more shorter cases and just talking about some short surgeries where actually taking that history is so important. So patients who have had for example, a cystoscopy, a lot of the times what they're having is bladder spasms, and giving more opioids or giving some other regimen may not be as effective. So using anticholinergics like what you all use, Buscopan, that can be more effective in that patient population. Patients who have an amputation post-operatively may have phantom pain, and utilizing neuropathic agents for pain management, like the gabapentinoids, might be very helpful. We also have, I do a lot of neuroanesthesia when I'm not doing pain. That's my area of interest. And I see this in a population who has transsphenoidal, pituitary resections. These patients complain of headache, and it's usually CSF leak kind of headache. So actually taking a story and understanding that it's a post-dural puncture type of a headache might really change the trajectory of your pain management. And thus, I hope that I'm emphasize that it's not as simple as monitoring your blood sugar and giving a medication. It is seeing the patient as a whole. Number is just an intensity measure, but you want to see how it affects your interference in your mood, activity, appetite. You also want to see the type of surgery. Again, trying to match the type of pain to the type of surgery, and giving relevant agents that will help other than opioids, and always trying to use that opioid sparing thought process in mind. Though there is, again, to put like everything that goes on in the literature, and in 25 years of practicing anesthesia, I've seen this. I used to do a lot of epidurals in the beginning. We went away from epidurals, went to a lot of rectus sheath blocks and for abdominal surgeries, then started moving again to quadratus lumborum blocks, to erectus spinae blocks, which are kind of moving back towards the neuroaxis. So I don't know where we will settle, where the dust will settle over here, but we're finding with the gabapentinoids, if patients are above 65 years of age, we're seeing a lot of sedation and dizziness in this patient population. So we're either attenuating the dose or skipping it altogether in that patient population if they're not likely to have a neuropathic component to their pain. But I hope that that has given kind of a more rounded picture of how to manage the patient rather than just going by the number. Thank you so much.
And Angela, would you like to add something to that towards a procedure-specific anesthesia, and whether you use magnesium and ketamine in your acute pain management? These are some of the questions that have come up in the chat box.
Thank you, and thank you again for the opportunity to talk today, everybody. So ketamine and alternatives that can be used as an adjunct. I've used them in abdominal surgery. So as opioid sparing, there's definitely some evidence to support use of ketamine intraoperatively as an overall opiate sparing. We've started to move away from gabapentin, but we don't do a huge amount of very major surgery where I work. And we try and get patients mobilizing extremely quickly post-operatively in the enhanced recovery policies where we had gabapentin. And generally, a lot of my colleagues find that that delays their mobilization. And I'm just having a little look through some of the other questions.
Magnesium, do you use magnesium sulfate as part of your multimodal analgesia?
I do. I use it not just for its analgesic role, but I find it's very useful, particularly laparoscopic surgery, where you often get a hypertensive response. You can alleviate that quite well with the use of magnesium. It also has a useful role in general smooth muscle relaxation, so useful for bronchodilation, which is always good under general anesthesia. And it seems to have some beneficial effect on pain. So I use it, all my patients whose blood pressure will tolerate it, for laparoscopic surgery, major abdominal surgery. I don't use it a huge amount in less significant surgery, in the more peripheral stuff, unless a patient has a very significant hypertensive reaction. Though I was talking to one of my medical consultant colleagues this morning, who sees on the medical wards the effect of hypomagnesemia. So maybe slightly different to what we deal with, but she said generally being hypomagnesemic makes a lot of her more elderly, frail patients feel significantly worse. So she's finding even in the absence of pain as an isolated symptom, treating with magnesium is quite beneficial to a lot of her patients. So I think overall it's a very useful drug with very few negative side effects.
Dr. Bala, you mentioned about lignocaine. How often do you use it in your acute post-operative pain?
I actually used it for sake of completion, but we rely more on regional analgesia. And when you use that, the need for lignocaine is extremely less. And hardly we have used it in our clinical setting. So, but there are several studies which have shown using intravenous lignocaine as one of the opioid sparing analgesia. And I don't have any personal experience in using intravenous lignocaine.
Kayuri, we get a lot of patients who are on dual antiplatelets and coming for surgery. So sometimes we try to avoid the deep blocks and definitely neuraxial. So in that setting, we are beginning to use intravenous lignocaine. Do you have any experience on that?
So we were using a lidocaine for our spine patients. We were using a combination of lidocaine, ketamine, and Precedex, which is dexamethasone infusions. And what happened was, what we realized as we were going through our enhanced recovery pathways, we did not see lidocaine add to anything else once we had ketamine on board. So if you were to do ketamine, and that helped with the SSCPs and all the neuromonitoring that goes with it, lidocaine kind of blunts that a little bit. So our neuromonitoring neurophysiologist preferred us to use ketamine versus lidocaine. We do use ketamine even on our wards after surgery. We do use low-dose ketamine infusions. Our nurses on the floors have had to be trained. Our bedside nurses have had to be trained to how to monitor these patients once we have ketamine infusions running. But we do not typically use lidocaine infusions post-operative.
Right. Dr. Sendil, you have worked in India, in UK, and then in the Middle East as well. I understand that dexmedetomidine is expensive in UK, so it's not used as freely as it is done in India and perhaps the US. So how often do you use Dexmed in your acute pain service? For procedure-specific analgesia or otherwise?
We commonly use dexmedetomidine intraoperatively. The use of dexmedetomidine in the post-operative period is very less in our setting. Only thing is there have been some quite a few studies which came out. The incidence of bradycardia and hypotension is relatively higher when dexmedetomidine is used. So we rely more on multimodal analgesia, which comprises, as Dr. Balavenkatasubramanian said, and we also sort of rely more on opioids, still the traditional opioid, because in centers where multi-specialty centers where surgeries from all specialties are performed, still opioid plays an important role in the post-operative period. So that's what I would say.
We will come to that a little later, Sendil. Thanks for your inputs. Despite us following all the multimodal analgesia, even then we find tremendous inter-individual variability in post-operative pain. Dr. Bala, would you like to throw some light on why the same thing doesn't seem to work for different patients?
Yeah, I think it's one of the major challenges facing each one of us. 40 years of age, same surgery, two different theaters it was done. They come to the post-operative period the same time, same kind of tissue injury, same surgeon. But then you see one responding completely differently to the medications that you gave and the other one not. Initially, we thought it could be completely related to psychological factors and someone is probably exhibiting it more and some less. But slowly we have started realizing, though that could be a component, but there is another exciting component which is coming up. That is the pharmacogenetics and the pharmacogenomics on how the receptors on which the drug acts, the binding of the drug that you gave to the proteins, and the third one is the enzymes that metabolize the drug. So now it's becoming evident that the possible difference in inter-individual variability could be because of the way the drug works in a particular person, because of the genetic or the genomics change that happens. And now some studies have been done to, in the pre-anesthetic assessment, you take the saliva to examine the DNA sequence.
Yes, sir.
We take either a swab from the buccal mucosa or the saliva, and then do the DNA study, and then try to find out what kind of enzymes that are present, which will help us to tailor make the dosages and the possible drugs that we use. I think this is going to be the future of, because we need something to look upon every decade. So every decade we need to grow and progress. And I think the next progress will happen, will be incorporating, particularly to major surgical procedures, in the preoperative screening. We also do a genetic study and see and decide on the analgesics that we are going to give. It looks very exciting.
So we had this wonderful talk on pharmacogenomics by Eric Matte from Mayo Clinic. Maybe sometime in the coming weeks, I will ask him to do a follow-up talk relating to anesthesia and pain. Thank you, Dr. Bala. Everyone spoke about how the acute pain service needs to be continued over the first 24, 48, or maybe 72 hours. And Sharon and others will be quickly taking us through a few gadgets that help us do this. Sharon, would you like to elaborate on PCA and other pumps? Sharon, are you there? Yeah. Sharon, can you hear me?
Am I audible?
Yes, now you are.
Yeah, hello.
We can hear you. I think your internet is a little slow, so you can perhaps switch off your video and speak. That might help. So I think Sharon is having some issues with her internet. So meanwhile,
I'm back.
You're back. Okay, great.
Yeah.
Go right ahead.
Okay. Yeah. So talking about the different pumps which are available for analgesia purpose. So analgesia purpose, we use different pumps like the syringe pump. We have the PCA pumps which are available. We have the elastomeric pumps which are available. Now all these pumps work in a different way. Now coming to the elastomeric pump. Now this elastomeric pump, it's a pump which has a elastomeric balloon inside. So once we inject the medicine into the pump, the balloon gets inflated, and with this pressure which gets built up inside the elastomeric balloon, it pushes the medicine through a flow restrictor. Now the flow restrictor is kind of a dial which consists of different rate which is set. Now it's a preset rate which is given by the company personnel. So if a pump, so like for example, an elastomeric pump comes in a setting of 235 ml. Some pump comes in a setting of 5, 7, 12 ml. Now, these pumps are used for analgesia purpose. It can be given in the form of IV opioids, or it can be given in the form of it can be given through continuous nerve block infusion, where local anesthetic drugs can be administered. Now, the advantages of using these pumps, the elastomeric pump is basically it is not driven through electricity. You need not use any batteries to operate it. It is not even gravity driven. It's convenient to use. There is no maintenance required. Depending on the capacity of the PCA pump, which is available, capacity of the Baxter pump, which is elastomeric pump, which is available to us, we can use these pumps for maybe for 4 to 5 days. The disadvantage of these elastomeric pump is where if the patient has pain, he would be dependent on the nurse or the physician to administer any bolus top-up doses. As I said, it has a preset rate. So it is 5, 7, 12 ml. So if you want to reduce the rate, we can't do that. And if it is a 2 or 3 ml of elastomeric pump, which is available, if you want to increase the rate, we can't do that. It doesn't have an alarms kind of setting. So if any catheter is blocked, or if an IV catheter is blocked, so if because of the block, the drug won't get released. So there is no way that the pump will give you an alarm. Now, coming to what is the PCA pump. The PCA pump is a patient-controlled analgesia pump, which allows the patient to self-administer the medicine. So whenever the patient has pain, he need not be dependent on any nurse or the physician to come up and resolve his pain, whereas he can just press the button and his pain becomes less. Now, PCA pump basically has 3 settings. Like we have the background infusion, you have the demand dose, you have the lockout interval. Now, basically the lockout interval is a period where the patient, even if he wants to initiate the bolus is not received. So it's like a safety mechanism which doesn't allow the patient to overdose any kinds of opioid or any local anesthetic drugs. Now, the advantages of using this PCA pumps are, as I said, patient can self-administer the medicine whenever he wants to. The patient himself feels that he has a control of his pain. He can be a part of his recovery process. Now, these PCA pumps, they have an alarm setting. So if any block is there in the catheter, they will give you an alarm at a high pressure block, and then you can see why the medicine is not going on. This PCA pumps, it allows you to do even a minute specific changing of the rate. So if you want even to keep the rate as 2.1 ml, you can freely do it. Whereas for elastomeric pump, you can't do that. It's very important to educate the patient on this because there are times when if the education is not given properly regarding the PCA pump. So sometimes some patients says that we go and check the attempted dose and the given dose. So sometimes there are too much of attempted dose. So when we ask the patient why is he pressing so many times, sometimes they feel, oh, I felt that this is a call bell. So the education is very important of why the PCA pump is. So the use of PCA pump should be done. In fact, decision to provide PCA pump should be done pre-operatively. The use of these PCA pump, especially in children and older patients who are not able to comprehend your instructions, it should be limited to them, because then. Now, with these pumps which are available to us, like maybe the elastomeric pump or the PCA pump, these kind of pumps will definitely, the use of these pumps will definitely help us to improve the patient satisfaction and the patient outcome. Also, recently, we had done a study where we had compared, we had taken around 40 total knee replacement patients. So both were on epidural analgesia. Now, 20 were given elastomeric pump and the 20 were given PCA pump. And with the result, we came to know that the PCA, the mean score for the elastomeric pump, it was little higher compared to the PCA pump. And of course, for the elastomeric pump, we had to give around, for the 20 patients, around 12 patients had to receive rescue analgesia other than the epidural analgesia, whereas only 2 patients in PCA pump had to receive other rescue analgesia.
Thank you, Sharon, for that comprehensive information on pumps and PCA. Sendil, I interrupted you when you were talking about using of narcotics in the floor. So would you like to go ahead with that now?
Sure, yeah. Opioids, I think in the era where we are moving slowly, into the area of opioid-free, analgesia, we still strongly believe that in centers where sort of multiple specialty surgeries are performed, there is a significant role for the opioids to play, particularly in the post-operative period in the wards. So when we talk about opioids, use of opioids in the wards, which implies that we are talking about procedures or surgeries, which causes moderate to severe pain, more than 3 on the NRS scale. For those surgeries where nerve blocks or epidurals are out of question, still the opioids plays an important role in the pain relief during the post-operative period. So is it really safe to administer opioids in the wards? I would say yes, provided we have adequate nursing and adequate monitoring. So what is the real advantage of using opioids in the wards? It gives a kind of predictive pain relief, obviously it's part of multimodal analgesia with your paracetamol and non-steroidals on a regular basis. So what are the types of opioids, and what are the routes which it can be administered in the ward? We have a variety of opioids commonly used in the wards for post-operative pain, starting from short-acting opioids like
Disconnect audio.
I request everyone to mute themselves other than the panelists. The rest of you, please mute yourselves. Yes, Sendil, sorry.
No worries, no worries. So we have, fentanyl, morphine, pethidine, oxycodone, so a range of opioids. So we just have to choose, the suitability of a particular, surgery. In a typical major surgery where we couldn't perform an epidural or major nerve blocks or continuous regional analgesia with indwelling nerve catheters, we rely on PCAs, the patient controlled analgesia. I'll just give a case scenario. So for example, a major laparotomy patient whom we couldn't do any kind of epidural or any kind of rectus sheath catheters or any other nerve blocks. So our typical regime would start like this. So we institute them on IV PCAs. It could be either fentanyl or morphine. If they are allergic to morphine, then we've got alternatives like oxycodone or pethidine PCAs. So we initiate these patients with PCA, and these PCA pumps are very sleek and easily transportable. The patients can walk around with these pumps, and even we have disposable, PCA syringe pumps available nowadays. So day 1 and day 2, we rely on intravenous narcotics, in the form of PCAs. Then and obviously we look and assess those patients and on a daily basis and how they're doing and how their pain pain scores are. So slowly from PCA we wean them off to parenteral narcotics in the form of subcutaneous opioid or intramuscular opioid. Subcutaneous opioid is better than intramuscular for two known reasons. One is we could avoid a painful intramuscular injection, and intramuscular injections can take longer. So subcutaneous opioids can be safely given in the wards. For example, morphine can be given subcutaneously and with 6-hourly interval, or if necessary 4-hourly interval. This can be safely administered in the wards. And day 2, day 3, and day 4, when their pain subsides, then slowly we wean them off, from parenteral opioids to either oral opioids, or if they are doing really well, we just continue them with, if necessary, opioids in the form of PR and opioids and regular paracetamol narcotics. So this is how our typical post-operative pain regime works in patients whom are deemed unfit for an epidural or a nerve block catheter or nerve blocks. Majority of the orthopedics, orthopedic patients, there's no doubt about it. They all invariably get a nerve block, and they get some kind of a.
So Sendil, there is some post in the chat box also, and in general, in all the Facebook groups and other WhatsApp groups, there seem to be in India, people are using transdermal patches for acute post-operative pain and acute pain. What is your take on that?
Yeah, transdermal patches have been were being used in the past, and then it went out of practice, and it was particularly the commonly used buprenorphine patch was deemed only for chronic pain, to tackle chronic pain, cancer patients, or chronic pancreatitis pain or whatsoever. But slowly, buprenorphine, particularly the buprenorphine transdermal patches, are coming into play in acute post-operative pain, and thanks to those a couple of studies which came out in the last couple of years. So transdermal buprenorphine is getting slowly popular. So what are the advantages with this buprenorphine patches? It's a sustained release, transdermal patch, which sort of predict, which acts in a very predictive way. I think Shireen has experience with these buprenorphine patches. Typically, these patches are applied about 8 to 24 hours pre-procedure, before the surgery. They are initiated provided the patients are fit to have a transdermal patch, and then it's continued up to a week in the post-operative period. And the studies which came out in the last 2 years have shown that it has been very useful in significantly reducing the post-operative pain and the easeability and unwanted side effects like with parenteral opioids like constipation, nausea, pruritus. All this, the incidence are pretty low with transdermal buprenorphine, they say, and more importantly, the drug likability, they call addiction is very minimal or almost none with buprenorphine, they say. Fentanyl patches, there is not much evidence for it, in acute post-operative pain relief. So I can't comment much about fentanyl patches. Obviously, it's got a big role to play in chronic pain. But yeah, definitely buprenorphine patches are coming into play in post-operative pain, and it could be
so
a very
completion. Sendil, what about NSAID patches?
Non-steroidal patches. I don't think there is any significant difference in using a non-steroidal patch compared to your oral analgesia. If the patients are fit enough to have oral pain medications, then I don't see any role in having these non-steroidal patches. That is what my take would be.
Thank you, Sendil. We are running a little behind schedule. So Angela, long-acting opiates and enhanced recovery don't seem to be words that we should be using together. So where are we going with this, long-acting opiates and ERAs?
Thank you. So just as a little bit of background, enhanced recovery was a principle first proposed in the late 90s in Western Europe, with initially a focus on colorectal surgery, but since then it's gained favour, as I'm sure you've all come across, in multiple surgical specialties. Currently, where I am, I'm working with enhanced recovery pathways, both in colorectal, but also in orthopedics and gynecology. And for patients able to take oral analgesics, one trend that developed was to use long-acting opiates in enhanced recovery pathways to provide a baseline of analgesia. And in the UK, OxyContin gained a lot of favour in enhanced recovery protocols. However, experience, further research into modified release opioids has suggested they don't have significantly more favorable profile when it comes to safety or to addiction. And concerns have also been fueled in part by the opioid addiction crisis in the UK, which I'm sure my US colleagues have had some experience with. And one of the issues they've had is that persistent post-operative prescriptions of opioids has contributed to an increase in its long-term use. It's increasingly suggested that in the multi-modal analgesic protocols that we all use for ERAS, the opioids are used for pain rescue only, like a lot of my colleagues have already suggested today. And the use of opioids only for pain rescue is inconsistent with the principle of using routine long-acting opioids for the majority of our patients. There's some safety concerns. So for quite a while now, the use of background infusions of opioids has been considered to be unsafe outside of the closely monitored critical care environment because there's a risk of accumulation, and for oversedation and opioid-induced hypoventilation during periods of low stimulation or low pain. As we know happens with acute post-surgical pain, it waxes and wanes, and it does improve quite significantly quite quickly. And long-acting oral opiates can have a similar effect to a background infusion of opiates. They also have quite a lot of their effect on resting pain scores, and with the increasing use of functional pain scores, which my colleagues have mentioned, and the use of really early mobilization and enhanced recovery, we're trying now to get our hips and knees moving within hours of their surgery. We're looking for analgesics pain management options that are good at reducing pain on movement more than at reducing pain at rest. And as I've said, acute post-surgical pain reduces in severity quite quickly in the majority of patients, over hours sometimes, but definitely within days. And again, using long-acting opiates as a standard for everybody doesn't really fit with the physiology of acute post-surgical pain. There's an arguable advantage in that on busy wards where controlled drugs take some time to access and deliver, some analgesia is often felt to be preferable to delayed analgesia. However, the counter to that is that on wards that are too busy to provide timely, when required, PRN medication, could also be argued they're too busy to monitor patients for the increased risk of sedation and respiratory depression that go with long-acting opioids. The Association of Anaesthetists, which is a UK-based association, summarised a lot of these issues really well in an international consensus statement they released in October 2020. Amongst others, there was the advice that long-acting opiates shouldn't be used routinely for the management of post-operative pain, and that opioid analgesia should be guided by functional outcomes rather than by static pain scores. We went to a conference recently on acute pain here in the UK, and this was the topic of discussion. It was the discussion topic, open panel discussion topic for the conference, and this was the topic that was raised. I think ultimately it came down to almost a 50-50 split, but there's definitely increasing evidence and opinion that they shouldn't be used routinely post-operatively. Thank you.
Thank you, Angela, for that lucid explanation. There was a question in the chat box, and I'm happy to say that it was already part of our plan. Sendil is now going to take us through how to go about setting up an acute pain service. Sendil, over to you.
Yeah, sure. Thank you. To begin with, we need a proper structure, to form an acute pain service. So it starts with the lead clinician for the acute pain. Basically, the anesthetist should be interested and or should be qualified enough to start up a service. So it all starts from there, and then we need trained pain nurses which who will be supervised by these anesthetists or physicians, and then these trained pain nurses will then train a cascade of ward staff. So these are the sort of training and personnel which we need. Importantly, we need to have adequate equipment, and I think Shireen had gone through some of the equipment which we need to use in acute pain service. and we need to have a standard operating procedure in the form of policies, and guidelines. For example, if we are planning to provide PCAs, then we need to have a clear policy and guideline. What drugs are we use and what strength we are going to use. So it has to be a standard drug preparation. Same thing applies with epidural. What are the standard solutions we are planning to use for the pain service? So once we get the personnel, the equipment, and the policies and protocols and guidelines in place, then we could well start a pain service. So the acute pain service, they are in charge of looking after post-operative pain in all surgical patients, and they also sort of get referrals about acute and chronic pain patients. So we need to have a bit of knowledge about chronic pain patients too. So these where it's feasible, there should be a daily ward round by a physician, if not by the trained pain nurse like Sherin, who goes around, sees these patients and then feedback to the lead clinician, who exactly are on PCAs and what exactly, how long it's been needed and everything. So it's a kind of teamwork, which starts from the clinician to to the ward nurses. The training plays an important role in acute pain service. The ward staff who receive these patients with the PCA pump or epidural pump should be capable enough to look after these pumps, because troubleshooting can occur at any time. So pump training is an important element of training these ward nurses. Those nurses in ICU areas and recovery areas should have the training enough for them to sort of refill the PCA pumps and epidural pumps on their own. So this is a kind of a structure we need to set up a pain service. I presume this structure applies for big hospitals, whereas in a smaller hospital settings, a good pain nurse like Sherin probably would do the majority of the work under the guidance of a lead pain clinician. And I'm sure she also would be training all those ward nurses in looking after the pain pumps and epidural pumps and everything. And then we periodically audit our practice, how we are performing and the patient satisfaction scores and everything, and then produce the data every year and analyze those data, and this is how a pain service works.
Thank you, Sendil. The backbone of any acute pain services are the pain nurses. Sherin, can you take us through a typical day in the hospital for you? What exactly does an acute pain nurse do?
So whenever someone asks me what is my job role and I say I'm a pain management nurse, the next question what they tell me, are you a pain-free nurse or are you a painful nurse? Now, definitely I'm a pain-free nurse, but the best part of what I do is to alleviate my patient's pain. Now, I start my day when I take a handover from the anesthetist uncle who was in the night. So he gives me a list of patients who are post-operative patients, what are the infusions which are going on at what rate, whether an on-call anesthetist in the night, he received any calls where he had to give any additional rescue analgesia. Now with this handover, in the morning, I go along with the morning on-call anesthetist. Before meeting the patient, we go through the patient's file for any what the patient is at present receiving any treatment, what are the vital signs, and if any investigations are being sent, what are the test results. Then we meet our patients. We assess the pain. We ask the patient how his night went, whether he was able to sleep, with mild pain. We also check if the patient is having any PCA pumps. We check for what were the attempted dose and how much dose were given. So accordingly, the pain is managed and titrated with the patient's needs. We also check for any side effects if the patient had. For example, for opioids, if fentanyl is going on, we check if patient is having any nausea, vomiting, itching, or any breathing troubles. If it is for side effects for the epidural analgesia, any motor block is present. So accordingly, we reduce the rate or we stop the drug for some time depending on the patient's pain score. Now, after the rounds are over with all these patients, my job is not done. I have to again frequently meet these patients at least for 2 to 3 times in a day. So I have to coordinate as well as with the physiotherapist. So as I said earlier, if patient has a motor block, so I need to connect with the physiotherapist whether the patient's motor block got receded, whether he was able to walk with mild pain. Other than this, I am at my hospital. I am the only nurse who's in the ward, especially I'm the only nurse who is privileged to administer under the supervision of anesthetist to administer the IV fentanyl, IV morphine drugs. No ward nurses are allowed to prepare and administer these kind of drugs. Also, as I got trained with the anesthetist, I am privileged to remove these nerve blocks. Maybe it is epidural, it is an interscalene, it is a femoral nerve block, or it is a ESP block. So these catheters, I can remove it. I can, in fact, I can also refill and fill the local anesthetic drugs which are given through these nerve blocks, which are the bupivacaine, ropivacaine. None of the ward nurses are privileged, not even ward, even the ICU nurses, no nurses are privileged to administer these kind of drugs. So I am the only one, along with the anesthetist, who can administer these kind of local anesthetic drugs. Now, with that, I also have a part where I have to educate my patients. So if I have to start any IV fentanyl or morphine, I need to educate my patients what kind of side effects it is expected out of that. Also, I have to educate on the PCA pumps, whether they have really understood, and I have to redemonstrate. I have to ask them again, what have they actually understood? So we also get many reference from different maybe as an ICU intensivist or some other clinicians where they refer the patients to us. So I am the only first point of contact where I get a call from the in charge or from the nurse saying that so-and-so a physician has advised us to meet this patient to manage the pain. So basically, my role is a very important role to in this acute pain service, where I am the first point of contact for everyone in the hospital. So especially I thank my team for training me and making me confident in what I'm doing right now.
Thank you, Sharon. I am sure all the nurses who have logged in today will be inspired, and maybe some of them will decide to take up your specialty. So Dr. Sendil did mention about feedback briefly. Dr. Bala, would you like to tell us how you do your feedback in your hospital and what you would recommend for those who are working in smaller setups?
One of the most important things is the night on the day of surgery for the patient. The daytime, the hospital is flooded with people, and there are a lot of people who can make decisions, but it's the first night that they go through. Here is where the feedback is of great relevance. And the next day morning when the rounds are made, until otherwise the institution has got an excellent hospital information system, you just need to go sit in front of that and see what all happened to your patients who underwent surgery the previous day. If you don't have a good hospital information system, then I think most important thing is the feedback that you get from the ward nurse, from the surgical colleagues, and from the physiotherapist. I think plays a huge role. And we've also seen this is important to modify our plan and strategy in even dosing the drug. For example, when you institute a block as a component of multimodal analgesia and you add a dexamethasone to that, if you have not put a continuous perineural catheter, they're pretty good on the daytime, and the night becomes very, very unbearable pain for them, because when the block starts wearing off, the pain recurs in spite of your multimodal. So this feedback that you get from the patient becomes very important the next day to make sure that how you make things better, and the next patient who undergoes a similar surgery, what you can do differently. So the feedback from all these quarters will make the whole APS robust, and this should be a component of every APS.
Thank you, Dr. Bala. Sendil again mentioned about how audits are central to any service, especially acute pain service. Kayuri, would you like to take us through what you do in your place and what you think can be done where the setup is not so, formal?
I can speak to the hospital, like a bigger hospital setup. And what we currently do is to try and assess. We have regulatory metrics that we have to follow. Our Joint Commission wants us to do certain things. And one of them is, most of these are actually nursing metrics, where is pain being assessed every 4 hours? Is it being reassessed after an intervention, IV versus oral, etc. So we see the percentage of times that the nurses are doing that. And this is globally at the institution level. We have that metrics and a running chart that we are seeing how the nurses are performing. Then to see a quality metrics, we try to see the quality of pain control that we're providing to our patients. And again, at an institutional level, we define it as the amount of time the patients have severe pain. We then want to even look at our safety metrics, and we use the use of naloxone as a surrogate measure for safety. So if we have had to give a naloxone, and we may not be doing a great job of our opioid prescribing methodologies. And so our pharmacy gives us reports on how we are doing with a naloxone administration, and we keep track of that, review the cases, and see if there is a change in our practice in terms of opioid utilization. And finally, we're looking at patient experience metrics too, and trying to see how many times the patients call us back after discharge. What are they calling us back with? Are they calling us back because we didn't give them adequate instructions? Are they calling us back because we didn't give them enough on the prescription? Or is their pain truly not well controlled? So this is more at a global level. At an acute pain service level, patients are when they're in the hospital, of course we'll ask them, but after they leave the hospital, our surgeons are our best kind of conduit to get us feedback on what works or does not work. So to give an example briefly, we had started using quadratus lumborum blocks for our hypothermic intraperitoneal chemotherapy surgeries, which have a lot of visceral pain. Our surgeons would then come back and tell us, like, we used to do epidurals and then we moved to this QL blocks. And the surgeons tell us, like, I know when I see this patient in the post-op course, when they walk in, if I know which patient got an epidural and which one had a QL block, and I can make out how well their pain was controlled. And so that's the kind of feedback we look for. And you know that the patient who had an epidural without any complications had a really good experience, versus the one who had opioids, was nauseous and still not very comfortable. And therefore, the importance of treating the pain early and treating it well, so that post-operatively, even long-term, they have better analgesia and better recovery process.
Thanks, Kayuri. We'll take up some more questions during the discussion. Most of our discussion today has been in the perioperative setting, but acute pain service has to extend to trauma, and Dr. Balavenkat has been one of the pioneers in starting acute pain service, the on-arrival blocks. Dr. Bala, would you like to tell us the pros and cons of on-arrival block and the challenges of expanding acute pain service to the ER and the rest of the hospital?
I think to be an anesthesiologist, to be called an anesthesiologist, the best ever thing that we can do is alleviate pain for every trauma victim who comes into the hospital. So over a period of last 2 decades, we have evolved the strategy of administering the block immediately on arrival to every trauma victim. So it needed the expertise 24 hours. So we made sure that we have 8 anesthesiologists on call every night to look after the ICU, and a couple of them are exclusively to give blocks for patients who come. For example, a geriatric hip fracture comes at 3 a.m. in the morning. immediately after sending the investigations, and then the patient is sent for a block. So we either give a PENG block or a fascia iliaca plain block and make him comfortable. And believe me, this is one of the best things that we can ever do to a trauma patient. A geriatric patient with diabetes, hypertension, coronary artery disease, I think the best medication that you can give them, usually pre-block, if you see they're very anxious, they are very uncomfortable, and the BP shoots up, and the minute you administer the block, about 20 minutes later, if you see the hemodynamics, they just settled very well. So the best antihypertensive and the best one to make them believe that they're going to live in a geriatric hip is to give a fascia iliaca block on arrival, irrespective of the time they come into the hospital. If you get a major polytrauma, we have evolved a strategy that the patient comes in with unstable hemodynamics, so immediately is shifted to the resuscitation room, which is the ante room of the operating theater. Here, the senior anesthesiologist and the support team, the best services are there throughout the day. And primary survey, resuscitation, block. This is the way we go about. For example, a patient comes with a mangled upper extremity. He had a fractured rib and got a fractured femur. So initially, primary survey, start the process of resuscitation, get the pressures to the level of permissible hypotension, about 80 or 100 if it's got a head injury along with that. Now, institute a block. Just record we take pictures of the injury. Sometimes the time is so short and we need to work very fast. So we take pictures of all this, and then these are all put in the case sheet. And if time permits, we do a quick assessment of the neurological deficit that is present in the injured area. And after documenting that, we go and institute the block. So for example, this patient will have a costoclavicular block or a subclavian perivascular for the mangled upper extremity, a serratus anterior plane block for the fractured ribs, the anterior ribs, if it's ESP, if it's the posterior. And then for the femur, you go for a fascia iliaca block or a femoral block. But this has made a considerable difference, not only in decreasing, alleviating the pain, but also in getting good radiological pictures. So we take, for example, if there is an injury to the upper limb, the surgical team wants an AP view, a lateral view, an oblique view before they go ahead. And here, once you institute the block, X-rays are done in the resuscitation room. So instead of patient going through the pain of getting these X-rays done in various positions, it's do the block and take the X-rays, which has made a huge difference. This is the best way forward for every trauma unit across the globe to make the services available 24 hours. An ultrasound machine, a person who is capable of administering it should be there throughout. Now, what are the flip side of it? The most important thing is making sure that you document the neurology of a pre-existing nerve injury. Number two, there are certain specific injuries which are prone for compartment syndrome. So if you administer a block in this patient who may go for a compartment syndrome, for example, fracture of the upper tibia is highly prone for compartment syndrome. And if you give the block and alleviate the pain, you may miss a compartment syndrome. So these are specific fractures where you need to be very cautious. And if you have done a block, you need to monitor the patient post-operatively to see for any vascular compromise. But I'm more than convinced that every trauma unit in this world should have extended acute pain service to all their trauma patients, because it makes a huge difference in decreasing the pain and the outcome. And also, I believe if you do the block on arrival, the chances of developing chronic pain syndromes will become much, much less. This is my submission on arrival block in acute trauma.
Thank you, Dr. Bala. We've talked about perioperative pain. We've talked about trauma. The next step forward seems to be an acute pain service that covers non-surgical, non-trauma settings. Angela, you want to say something about that?
Thank you. So I'm a fairly recently appointed consultant in anesthesia, and I took over the acute pain service here in the midst of the COVID epidemic. So my experience so far has been slightly coloured by that. But the team that I joined has evolved from a perioperative pain management team. However, it still only works with patients within our cancer and surgery directorate. So the hospital I work in, that also means we've got patients belonging to the Division of Medicine and Emergency Care and the Department of Women's and Children's Medicine, which we aren't funded to cover. Now, the service started as a perioperative pain management service. And at the time, there were quite a few epidurals being used for post-operative analgesia. The number of epidurals that have been used have gone down since 2001, but that's been replaced by the use of post-operative PCAs. So the majority of patients seen in terms of numbers by our service is titration of their post-operative PCAs. But in the last few years, there's been a definite increase in the amount of time required to manage non-operative pain in surgical patients. So, for example, the acute pancreatitis, the acute back pains, and the management of acute on chronic pain, with chronic pain in the UK becoming much more common and widespread. Now, these patients who aren't perioperative are usually much more time consuming. We don't have a standardized protocol for managing them. And the increasing pressure to avoid and deprescribe opiates means that managing is becoming a lot more complex. Now, during COVID, a lot of our patients were redistributed to medical wards, and this gave us an opportunity we didn't realize we didn't have to discuss pain issues with our colleagues on the medical wards. And we realized not only is there a significant burden of acute and acute on chronic pain on our medical wards, but also there's a lot of crossover with our surgical patients. Now, a lot of the bigger hospitals in the UK do have acute pain teams that cross cover both surgery and medicine. But for those who are listening to this, who either don't have an acute pain service yet and are thinking of setting it up, or are developing a perioperative pain service, it's to say, keep an eye on where your service might develop. But also, if you're setting one up, don't limit yourself to just managing perioperative pain. There's a real burden for pain in medical patients as well. And to be able to support our medical colleagues and help our patients with pain, being able to deliver an acute pain service to them is of some real benefit. So here in the hospital we work in, to expand our service, we're going to have to numerically demonstrate the need for an acute pain team on the medical wards. So we've had informal discussions with medical consultants, with the nursing ward managers to get an idea of what they'd like from us. But we're going to have to get some numbers to put behind this. So we need to define any risks through not having an acute pain service on medical wards. We're going to have to audit against national standards. Now, there we go. So in the UK, there's a publication called Core Standards for Pain Management Services in the UK. And that's a really useful resource to be able to audit against. And also for us, NICE standards as well. And another way is that we're introducing some of our acute pain pathways to the medical wards to demonstrate how useful they are, both for patients and for supporting the clinical teams. And the one we've introduced most recently has been the protocol for management of acute rib fractures. Now, we're not a big trauma centre, but what we do get with our rib fractures, as Dr. Balavenkat has mentioned with his patients, is the elderly, the multiply comorbid, those having polypharmacy, and managing their pain is actually quite complex, and there's quite a few of them on the medical wards. Our intention initially, developing from a peri-surgery service, is to begin with conditions which have got parallels to our surgical and orthopedic experience. So acute rheumatological pain, acute gastrointestinal pain, and then with additional training and with additional experience to progress into supporting our medical colleagues with more complex conditions. However, I have a suspicion that once we start, the referrals will come pouring in. Throughout, our intention is going to be to support opiate deprescribing, because that really is the way pain management is going now for us, and to introduce, to support, to facilitate non-opiate pain management options. Just as a little end, sorry, Vidya, the Faculty of Pain Medicine here in the UK has got an education module called Essential Pain Management, and it uses a RAT system to recognise, assess and treat pain. And we're also introducing that to our surgical and medical colleagues to help support them in managing pain on our wards. Thank you very much.
Power to you with your new plan, Angela. So we'll wind up the formal part of this discussion by introducing the concept of transitional pain service. Kayuri, would you just brief us about that?
Yeah. So this is an emerging concept here in US, is taking the patient across from the pre-op all the way to post-op. And so this is more relevant for our osteoarthritis patients with who are going to go in for hip or knee replacements and have been prescribed opioids beforehand. So we try to wean them off their opioids utilizing multimodal analgesia by seeing them several weeks ahead of time. Sometimes we have to, as we are doing this transition, have to do a regional block to try and buy us time. Use physical therapy, do cognitive behavioral therapy, all of that up front, then use opioid sparing techniques, including regional anesthesia during their surgical experience as well as their stay. And if they get prescribed opioids, then continue to follow and see them post-operatively to wean them off. What happens here is like patients get a prescription and then nobody makes that effort to actually wean them off that opioids. People just keep refilling that prescription because they don't have the expertise or have the time to try and educate patients and wean them off the opioids. Well, this service kind of takes hold of the patient, takes them through the whole experience, makes sure that they are off the opioids, whatever number of weeks it takes afterwards. This is obviously very time consuming, and we are still in the process of building that up for our Cancer Institute. It is more of trying to get our patients adequate amount of analgesia and pain control before surgery, and that may mean utilizing pre-op multimodal analgesia so that they come to the ORs in a more comfortable state, not with their whole pain pathways revved up, so that they're more receptive to what we have to give them.
Thank you, Kayuri. And unless one of the panelists want to say something at this point, could we start taking the questions?
Yes, please. Yeah.
Yes, Dr. Bala.
There are a few points which I wanted to make considering the Indian scenario. We have smaller hospital, we have private institutions, and we have big corporate setups. So it becomes very pertinent that all that we spoke, if it has to translate into act, and making sure that irrespective of the infrastructure, if they continue to get pain relief, there are a few things which are very crucial for our country. And one of the most important thing, as enumerated by Sharon, is the elastomeric pump. The infrastructure limitation that is seen in some units, for example, they have 10 pumps, but that particular day they've done 20 surgeries. And it becomes important that to make sure that everyone gets a kind of infusion pump. So elastomeric infusion pump, one of the advantages that I've seen is, like Sherin mentioned, Baxter, and there are now quite a few of them which are available. We call it as multifuser, which starts with very low volume of 2 ml, and then you can change to 4 ml, 6 ml, 8 ml, 10 ml, and 12 ml. So multifusers are available now, which I think is a very good step forward. And number two, the elastomeric pump also has a PCA option with a few companies which have come in. I think this has made a very important component of pain management in smaller setting. So that was number one about elastomeric pump. Number two, there's a lot of discussion in using buprenorphine patch. Again, I would come to the limitations that are faced by some institution. The narcotic, the controller controls the narcotic distribution in a city. There are smaller hospitals which have not got a narcotic license, but there are a few drugs which can still be made available without getting, like in India, morphine, pethidine, fentanyl. If you need to have a license. But then you needn't have for buprenorphine patch. You did not have it for injection Butrin. You need not have it for injection Fortwin, which is used. So I think buprenorphine patch, in India, we get 5 milligram, 10 milligram, and 25 milligram patch. In adult population, predominantly we use 10 milligram patch. And many question, what is the use of using a transdermal patch in an acute setting? It works. It works because it's a multimodal analgesia and opioid requirement becomes less. So when you have used an effective multimodal, there is another component which pitches in, and that is buprenorphine patch. We use 10 milligram patch quite extensively, and especially when you nurse the patient in your post-operative ward at a high dependency unit on the day 1 and day 2, and when you transfer them, like what Dr. Kayuri said, a transitional pain service, when they go to the ward, the buprenorphine patch takes over because the patch can work for 5 days, and it's a very, very good adjuvant. And I feel in Indian context, I think this is a very important drug. And similarly, 3 other drugs, which is very important in Indian context, is I saw in the chat box, the role of Butram. Butram is Butyphenol. We get in India as 1 milligram and 2 milligram. This good option is, again, as I said, there is no need for a narcotic license, can be there in a smaller hospital. It's a very good analgesic with hardly any respiratory depression on other consequences like pruritus. So Butram is an excellent adjuvant in your perioperative care in Indian setting. The other 2 drugs, which also are a very important role that they play in India, is Tramadol and Tidal. So which are similar to kind of an opioid-like acting, freely available. And only issue with the Tramadol is sometimes patients are prone for nausea and vomiting. And when you decide to use Tramadol, then you can use antiemetic along with that. Tidal is another drug, 50 milligram 8 hourly or up to 100 milligram 8 hourly, forms a very good component of your multimodal, especially when you have a patient with high creatinine level, where you can't use non-steroidal anti-inflammatory. These drugs pitch in. A regional block, paracetamol, Tidal or Tramadol forms a good component of multimodal analgesia. These are the few points which I just wanted to enumerate, taking the Indian scenario into account. Thank you.
And Dr. Bala, to follow that up, could you just answer this question as well? Please elaborate on the role of gabapentin pregabalin in acute pain.
That's a good question. And one of the things which I've noticed in Indian population, as also mentioned by all the other colleagues, that one of the issues with the pregabalin and gabapentin has been the sedation that it produces. Now, there are several RCTs which have been done in using the pregabalin preoperatively, even 1 single dose. There are a few studies which have clearly indicated that it depends on if the surgical procedure resulted in a neural injury, even small nerves getting cut during the process of the tissue injury. Pregabalin does seem to have a role when it is used preemptively. Now here in Indian population, we use a much lower dose than what is prescribed in the literature. 75 milligram of pregabalin is what is used mostly, and we found that at this particular dose, the incidence of sedation is less, and their participation the next day in rehabilitation, including ambulation, is possible. However, when you use it on the geriatric patients more than 65, you need to have a very close watch to see even with low dose of 75 milligram, and some patients are oversensitive. In a nutshell, pregabalin is a good drug in a smaller dose for Indian population, 75 milligram, a dose given the day prior to the surgery, that night prior to the surgery, as a component of your preemptive. So we give paracetamol 1 gram, aceclofenac or ketorolac. Aceclofenac, if you use it, 75 milligram, pregabalin 75 milligram, a pantoprazole, and to induce a natural sleep when they're very anxious, we use a benzodiazepine. So this is the formula that we use for our patients. And I also believe that a good sleep the previous day is very crucial in decreasing the anxiety and the pain perception when they come for surgery.
Thank you, Dr. Bala. Kayuri, you mentioned about non-pharmacological interventions. So there's a question about acupuncture, acupressure. Probably you could speak on iontophoresis or anything else that you would like to answer that question. Is there any available update review of literature?
So we do have acupuncture services available, but they are only available in an outpatient setting. We don't have it available in an inpatient setting because we had issues with reimbursement from our insurance companies for these services. So they are great adjuncts if you were going to try to use them before the patient comes in for the surgery, and after they leave, we don't have access to that kind of service within the hospital. So they've just started using it. I think there was another question on other modalities like cryoablation, if I'm not mistaken. And our experience, though very limited, has been that it doesn't really provide great acute pain analgesia, but it does help with, if you start early on, it does help with attenuating the amount of pain. You still need to give your multimodal analgesias. Again, there's not a lot of experience, so it's very early to say what is the long-term consequence of modalities like that.
So how much ketamine do you use in the wards, Angela? There is a lot of questions about that. Boluses for rescue, for post-op pain, infusions, the works.
Personally, I work in a hospital that doesn't have ketamine available on the wards, so 0. Intraoperatively, I tend to do smaller surgery, so I'd use 5 to 10 milligrams, but the papers that I've read talk about 0.1 to 0.5 milligrams of ketamine use intraoperatively. I use it sometimes as rescue in recovery for patients who've had lots of opiates, all the other multimodals, and are still in pain. And then I do tend to give 5 to 10 milligrams as a rescue. But I'm afraid I'm going to have to pass the question to my colleagues who have ketamine available on their wards to answer the rest of it, Vidya.
Sendil, would you like to take that?
My answer pretty much would be the same like Angela, because it's not available for us to be used in the ward. But majority of the orthopedic patients do get a dose of ketamine intraoperatively, at sort of at a dose of 0.5 milligrams per kilogram body weight as a part of multimodal analgesia, and there have been studies which have proved its efficacy as part of multimodal analgesia. People have extended their use, the use of ketamine into other areas like in ENT, in tonsillectomies, in children, and everything. So ketamine is very much part of multimodal analgesia, but mainly confined to the intraoperative period. Ketamine has a big role, with the chronic pain physicians, in chronic pain patients, but in acute post-operative pain settings, our experience is very, very limited.
So maybe I can answer this,
yeah.
since we do use ketamine on the floor. We use anywhere between 2 to 6 mics per kilo per minute. That's our, it's a continuous infusion. If we have to give boluses, then that's when the physician goes in and gives a bolus, and the bolus is anywhere between 5 to 10 milligrams boluses. We rarely have to give boluses. This is usually in conjunction with other multimodal analgesics that we're using, because this patient population is probably very, very difficult to deal with. That's why we have to use the ketamine.
Thanks. If any of the panelists want to address any of the questions that are in the chat box, please raise your hand. Anybody from the audience would like to make a comment, please feel free to unmute yourself and speak, or raise your hand so that we can call on you. Vijay Sahitya, could you unmute yourself, please?
Hi, good evening, madam. I work in a neuro and spine center here in Liverpool in the United Kingdom. So I've seen the use of ketamine quite frequently. So it's either as a rescue on the wards. Mind you, on the wards, we always use oral ketamine. So if a patient's having too much pain after using up to opioids, we tend to give a 10 to 30 milligrams of a single dose of ketamine. And other population of patients which we receive are like chronic pain patients coming for a back surgery who are already on tons of gabapentins and more opioids and stuff. So in those, we use them in intraoperative period as well as in the post-operative period for 2 to 3 days. And the dose which I use here is like 0.25 milligram per kilogram divided into 3 doses, and give 2 doses in intraoperative and 1 dose in the recovery, and that works quite well with us.
Thank you, Vijay, for that explanation. We have Sai with us. Sai was the reason this session happened, because the Marvelous Medicine family has become a big one now, and I keep getting suggestions for topics, for speakers and works. So Sai, thank you for making us do this session. And Sai had a few pertinent points which I told her that we may not be able to address during the talk, but we can take it up in the discussion. Over to you, Sai. What are your questions?
Thank you so much, ma'am. My question is, when when we're trying to start acute pain services, there are some points from the surgeon's side. Usually our surgeons say, itna to dard hota nahi hai, and we are anyway using 4-Phenagon, our patient is comfortable, or they have to have some pain if we have done such a big surgery. So what did our people, our leads in acute pain services, what did they do to counter such things? Like, I just want some guidance.
I think one of the best things is to do the audit, because always we perceive that you have done, just by prescribing a particular drug, we think that we have done justice to the patient. But I think an audit which is done neutrally by a person is the best answer to tell the surgeon. And I'm absolutely confident that at least 60 to 70% of the patient population will complain of significant pain in the absence of acute pain service.
Thank you, sir. Thank you so much, sir. Actually, when we started giving nerve blocks also, we faced this. Now it's only because of this patients that we're able to do intra-op blocks. I hope this thing works for acute pain service also. Thank you, sir.
Tisha, you wanted to say something? Tisha,
yes, ma'am.
Yeah.
Yes, ma'am. Thank you so much. It was a wonderful presentation. I just wanted to ask you one thing, like even in a corporate institution, how safe it would be to give IV opioid infusion, like PCA pump, in a ward? Is it like, because the trained staff would not be there, is it safe enough to be given as a continuous IV infusion in a PCA pump in ward, I mean, without monitoring?
Sendil, would you like to take that?
Yeah, I wouldn't advise to give any continuous infusions in the ward. It's not safe. But PCA pumps, which has inbuilt, safety mechanisms, patients overdosing themselves is the possibility is almost nil. So PCA pumps can be safely used in the wards, provided the nurses have a sort of good monitoring facility. For example, if we prescribe a PCA to a patient, the vital should be monitored every 15 minutes for the first hour, and then every half an hour for the next 4 hours, and then every 4 hours for the next 24 to 72 hours. This is how the monitoring works. So firstly, the requirement, the ward staff has to be trained, what we call it as pump training. They need to know what exactly is going on and how to tackle with troubleshooting. They are not authorized to fiddle with the dosages or any alterations in the dosages. The pain service has to be called in to make any alterations or anything like that. All they can do is can change the batteries when required. So these are the limitations in the ward. But otherwise, for example, in the last year, in the year hit by COVID pandemic, where in our elective surgeries, the capacity to operate was reduced dramatically. Even with that, we have used nearly 2,500 PCAs in the last year in our corporation. So pretty much, more than 95% of these PCAs were managed in the wards. So provided, the ward staff are adequately trained, it's safe enough to administer PCAs through a dedicated PCA pump. There are a few things which are mandatory. The patient should have a dedicated IV line for the PCA, and there shouldn't be any sort of Y connectors or two-way connectors in that. It has to be a dedicated line for the PCA alone. And obviously the ward staff need the training to look after these PCA. So we kind of sign off certain competencies when these ward staff get trained, and those staff who complete those competencies are fit enough to look after these patients in the wards.
Okay.
Angela, you wanted to add something?
Yes, I just wanted to add to what Dr. Muthi said, which was all very relevant and pertinent, and what I would have said as well. One of the things that's very important with safety in patient-controlled analgesia is to protocolize it. And we have, I'm not sure my camera's going to show that because it's faded out. Every patient we have who gets a PCA has got a separate prescription chart with their prescription for a PCA on it, and with the required observations on the same chart. So within the first 6 hours, you need to do observations hourly, and after 6 hours to do 4 hourly observations. Patients must also have naloxone available to be given instantly, so it won't work somewhere if you don't have nurses able to give naloxone in the absence of a doctor's presence. And as Dr. Muthi said, the training of the ward staff is what is absolutely core to underlying the safety of PCAs, and also not giving background infusions outside a really closely monitored environment.
Thank you, Angela. Sai, perhaps the last question, and then we'll take closing comments from Dr. Bala.
Good evening, ma'am. Actually, I wanted to ask about the payment for this. Being a corporate hospital or a tertiary care hospital, most people come via insurance. So they're not ready to pay even a little bit outside insurance. So, and the surgeon is also very wary of this. So how do you take the payment for this? Because it includes pain rounds at least twice a day. Then it includes PCA pump and its charges, and a lot of consumables and other things. So how have we figured out this part?
Dr. Krishna Joshi, did you want to say something about this point? Please unmute yourself, sir, if you are going to answer this question. Dr. Bala, would you take that, because you pioneered this, so how did you manage the money aspect of this?
I think the most important thing is to discuss with the patient in the preoperative period itself. When you do the pre-anesthetic rounds and counseling, you need to tell about the expected pain and tell that this would cost this much extra. And believe me, even elastomeric pumps, initially everybody said, where will the cost come from? Now, every single patient wants absolute comfort in the post-operative period, and I don't see a reason why they have to quote insurance. I think the money and the pain cannot equate each other. It all depends upon us to counsel the patient, tell that this is what, and the comfort levels. And in fact, you can have a couple of videos with pain, without pain, with the face covered for a similar surgery for patients who have undergone this process before, and they will immediately jump into saying, doesn't matter how much of a cost, I will take the medicines, including whatever you would want it to give in the acute pain service. So that's an easy way of convincing your patient, but it starts in the preoperative period. And
before you close, sir, Dr. Raghavendran, thank you for joining us and staying throughout the program. You have also got experience of corporate setup, and would you have any pointers for Sai as to how to go about convincing patients and surgeons and the management that we need to spend some money to control pain or run an acute pain service?
Vidya, am I audible?
Yes, sir.
Okay, thank you, Dr. Vidya, for inviting me and be a part of this program. Very wonderful program so far. So many valuable points shared. can I add a few points here and there, practical points, to whatever has been said before? See, what I found in my experience is that preemptive analgesia is actually plays a major role. See, we started doing tap blocks earlier, and after we started giving tap blocks, if we do it before the surgeon starts the surgery, it has got a better effect. It's been proved, and then we have statistical data to support this contention. And in my what I feel is that even though they say that the role for the neuraxial blocks not much nowadays, but I think I've come back to intrathecal morphine, and I found that it is playing a very major role in post-operative pain relief. And it can really dispense away with epidurals and really helping us a lot. Okay. And I don't go for a narcotic, we don't give narcotic free, but we can give narcotic restricted anesthesia. So it does have a role. And as part of, I would say, a multi-modal. I don't keep it as a main analgesic, but I think mix it up with other agents like magnesium and clonidine and lignocaine, all these things. It really helps a lot. And wherever there's a nerve, there's a possibility of a nerve block. Please remember that. And one thing which is very common, which is going to happen is, if you don't relieve the pain, acute pain, it's going to lead to chronic pain. So you're going to sort of give more patients to a chronic pain specialist. So and one more thing which probably, which we can also take into consideration is the relief of pain for acute labor pains. So this again, the acute pain specialists should take it into consideration when they are dealing with acute pain management. Okay, so the points I just want to share with you. And as far as the motivation for us is actually, it should be coming from all people, from surgeons. Luckily, I have been working with Dr. Radhakrishna, who is very keen about his patients not to suffer any pain. So it's quite easy for us. But sometimes it takes a lot of convincing to convince surgeons to accept the pain management part. And an initiative has to come from us and support from them. And that's what it makes the whole program successful, and it goes quite well. Thank you.
Thank you, sir. Angela and Sendil, does your acute pain service cover labor as well?
Yes, because they use a lot of epidurals, and we look after those epidural pumps. And we have this policy which we revise once in 2 years, what kind of local anesthetic solution to be used for labor epidural. And we have a local pain lead in the women's hospital and to overlooking all those labor epidurals. Yes, acute pain service very much cover the
labor. Angela, what about you?
No, so for us, the obstetric epidural service it's run by anaesthetists, but it's probably so common and such high volume that the acute pain service doesn't get involved because the protocols and standards we have are already so well set, and every patient in labour with an epidural has one-to-one supervision with a midwife who will be experienced and trained in managing those. So we don't find we have to be involved at all with acute pain in obstetrics.
So we don't have that luxury in India. So perhaps if somebody starts an acute pain service, they'll have enough to do from the word from day one. Dr. Bala, your closing comments, please.
Madam, I think at the outset, I would like to thank you for coordinating the session so very well on a very important topic with direct clinical relevance on a day-to-day basis. And also because not only our country, but globally, we still find the comfort levels and the pain relief in the first 24 to 48 hours is grossly inadequate. And we need to do much more work. So this particular session threw a lot of light on that. And for the listeners from India, I just need a few things from you, very simple things. For example, we need to see what medications are written for post-operative. Who writes this medication? Is it the surgeon or is it the anesthesiologist? If it is surgeon, I would request all the anesthesiologists watching this program to discuss with the surgeon and then set the protocol and write. Next important thing is when they write the prescription of a multimodal, it's very important that we should not put BD, TID. It has to be, you need to write the time in which it needs to be administered, 2 p.m., 9 p.m. This will aid and assist the nurse to exactly give at the time. So you have planned to make sure that the plasma levels are maintained based on the drug you use. So small and simple things would make sure that acute pain is taken care of. We need to do a lot more. And best thing is every month you should at least individually audit few of your cases to see, have we done justice to what we have learned, and has the patient been comfortable? And this will be a great learning process which will instigate and induce us to do better to our patients. But eventually, I think we have the power to prevent pain. And if we don't use it appropriately, it's a gross injustice to our patients. And I'm sure that together we'll have to win this war against pain and contribute more to making it happen clinically in the ward every day to every patient whom we anesthetize. Thank you so much, madam, for that wonderful session. And I learned a lot from every faculty and the practices across the globe. Sincere thanks.
Thank you, Dr. Bala. Radhakrishna?
I should say it's one of the best sessions I ever part of, and it's mesmerizing. I wish more surgeons listen to this than who have joined, but I think I should apologize, say something. What I see at the head end is either the chief anesthetist or a registrar or a technician using some colorless injections every now and then, and everything goes on fine. I don't see what we do is seen by everyone, and what goes in anesthetist mind, nobody knows. I don't know what is the chain of command. There's no word, nothing like a Hollywood saying, movies, people shouting orders, nothing. Silently everything goes, and patient comes out so well. I never knew that pain service, pain management has got so much of intelligence into it. And I think there should be an occasion once in a while, as Dr. Bala says, that surgeons and anesthetists sit together and at least let the surgeons know that what amount of the science you are putting into practice to make patients painless. Thank you all. I think we are all so much indebted to such wonderful angels doing things silently, unsung. Many patients do not know that their pain is taken care by such wonderful anesthesia for the tissue trauma we create. Thank you all once again.
Thank you.
Madam, can I ask one last question?
Yes, please.
Madam, can I ask one last question?
Yes, please.
In the first place, excellent talk by all the panelists. Thank you all for enlightening the whole lot of us for what they have done. My question is to all the panelists for small scale surgical units. What would be safe, ideal multimodal analysis? Because that's one thing. There would be at least for every 10 corporate anesthetists, there are about 100 private practicing anesthetists. They would like to have some guidelines as to what should be a good multimodal analysis, which should be safe.
Dr. Joshi, even when there is a corporate hospital, many times the service is the same as what the freelancers are doing. So what we do is that we use paracetamol and proper doses, that like Dr. Bala said, 1 gram and 6 hourly, and we write the time. We don't, because everyone will adjust the time according to their convenience. So if I give an intraoperative dose at 10 o'clock, then I write that the next dose should come at 4, 10, 4, 10, 4 doses. And then the next day we switch over to oral or whatever. Similarly, we use diclofenac. Dr. Bala uses ketorolac, so we use 75 milligram diclofenac if there are no contraindications, and we use it 8 hourly. And again, we put the time, and we try to stagger the doses so that patient gets something every few hours. So that also helps to keep the pain relief better. And if there is a morning mobilization plan, then it is worthwhile trying to have a dose of analgesic going at least an hour before the mobilization was planned. Then, like everybody's mentioned, we don't use narcotics on the floor so much because we don't have that many PCA pumps, or we don't have supervision. So we use a lot of tramadol, and just like the oral combination of tramadol and paracetamol, despite being very small doses, the tablet Ultracet, I don't want to propagate any brand, but that's a commonly used one. The actual dose is very small, but patients have great pain relief. So taking a page out of that book, we have started using combination of paracetamol and tramadol in the intravenous route as well. So you can very well combine 50 milligrams of tramadol with 1 gram of paracetamol and run it every 6 hours. That's possible. And like Senthil said, we can use, though it is painful, we can use intramuscular doses in the floors because our Indian nurses are well trained for intramuscular doses. So we do use a combination of tramadol with a very small dose of Finargan, maybe 12.5 milligram. It takes care of the nausea and also provides some mild sedation without respiratory depression. And like Dr. Raghavendran mentioned, wherever there is a nerve that can be blocked, and so more and more of our young anesthetists are well trained in performing nerve blocks, and so distal nerve blocks are very useful in same day care. Patta, can you mute the person who was? Yeah.
It's coming from your background.
No. Okay, never mind. So yeah, so we all have to get trained for doing blogs. So if Dr. Bala wants to add something more, please go ahead.
No, I think you emphasized on regional anesthesia and analgesia. I think as the regional analgesia enthusiast, I think the single act of learning the ultrasound, putting a minimal dose with an adjuvant like dexamethasone, and make sure dexamethasone seems to be an excellent adjuvant for perineural. And if you use about 8 milligram, 18 to 22 hours is the analgesia that we get in majority of our surgical patients, though it's not pedicunate. I just wanted to say that once you have incorporated an excellent regional block with dexamethasone as an adjuvant, we needn't think about all the PCA pumps and the infusions, and the whole thing takes care of itself. And I think that should be the dream and the goal. And with possible availability of liposomal ropivacaine and bupivacaine across the globe, and when it gets sanctioned and prepared in a way that it can be used perineurally, 72 hours of excellent analgesia will happen to our patients. If that day comes in, then I think most of the things that the challenges that are there will disappear. Thank you, madam.
I can see that Kayuri is getting ready to go about her day. So thank you, everyone. And thank you especially, Kayuri, for staying longer than we anticipated.
Senthil has a comment to make.
Yeah,
yes.
Just one final point. In the era of daycare surgeries, where we are performing more and more procedures as daycare surgeries, please make sure that you send some take-home pain medications along with the patients, which I think is very important. We often sort of take it for granted. The patients are nice, fine, and they're going home. Just make sure at least 3 days worth of painkillers in the form of paracetamol, ibuprofen, whatever. Send them home with some painkillers. Let them have a nice peaceful sleep. Post-operatively.
Thanks, Senthil. Thank you, everyone, for we had a fairly record audience today. We are nearly 150 people logged in, and even after 2 hours, there are still almost 60 plus people here. Thank you, everyone, for joining in, and we'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Good night. Thank you.
Thank you.